We are able to see and hear you, Dr. Girish. And
Hi.
please,
Good evening, Dr. Srinivas.
yeah, please introduce your case. With me, Dr. Jai Thomas sir and Dr. Selvamani are there. And please go ahead and introduce your case.
Yeah, thank you. I wish the meeting all the great success and welcome to Bangalore Apollo today. I have with me Dr. Pranit, cardiologist, Dr. Ketan, my technician, and Mr. Dilip, my nurse, and many of them. This is about a 73 years old gentleman. Dr. Pranit, if you could introduce.
Is Dr. Gopal Murugan around? Gopal? Okay, please go.
PTCA to RCA in 2011. After he is comfortable now, he presented with exertional chest discomfort of class 3 from past 1 month. His LV function is preserved. Now angiography was done which shows a triple vessel disease. That angiography we are going to show, and RCA stent proximal to the stent shows significant ISR more than 95% with the extremely calcified vessel. Coming to the left side, it is a ostial left main and proximal LAD having a significant stenosis with proximal LCX having significantly calcified critical subtotal occlusion that we can see.
Thank you. Let's play the angiogram. Can we go forward? Yeah. Is that the first angio? This gentleman has had an angioplasty in 2011 for an acute inferior wall MI. And go back to the angiograms, please. You take.
Show the angio pictures first, please.
Yeah, give it to him. Yeah, you can. This is the left angiogram. You can see here. The LAD has got a diffuse stenosis. Only when we do an OCT, you would realize that the ostial LAD and distal left main has got a disease. And then the proximal circ. Next, yeah, you can see here the distal left main, please. Distal left main and frame by frame. Ostial LAD, you would see something. I will show you an imaging. Next, we'll go to the next circumflex. Come. Okay. Forward next. That's an OCT that we have done for the LAD. Circ lesion, can we show them? Yes, you can see here. Can you see the very eccentric calcified lesion? We just had a little challenge crossing, and then but wire has come back again because microcatheter got stuck into it. Keep playing that. So that is the lesion that we have. Could you also show them the RCA? Go back, please. Yeah, this is the wire. We'll just go back to the RCA. Come back. We just wanted to prep. We thought, before you all join, we should finish at least the RCA. This is the lesion and very, very tight calcified lesion. Go next, please. Didn't take a diagnostic.
You don't have a baseline RCA picture, just to have an idea? Before you did PC?
There was a CD, yeah. Can you play that? Yes. Freeze. Yes. I mean, this is after pre-dilation.
Okay.
This is how it looks. All right?
Okay, go ahead.
So basically proximal stent restenosis or what?
Yes, Dr. Selva, if you could just see can you play that images, OCT? I will show you in RCA. Can you go back? We had slight challenge in terms of, OCT being connected with an ACR. So we're just showing you on the screen. Are you able to see the OCTs?
No, we're seeing angio now.
Yeah, yes.
Yeah, now we see those.
It's coming on your screen.
Yes.
Yes. You'll be able to see the distal to the stent. It's not really an ISR. Distal to the stent, there was significant critical stenosis and also very proximal to the stent, at the proximal edge of the stent. As it comes in, you can see here, there is significant fibrotic plaque along with calcium and lot of lipid-rich plaque too. You can see here. Yes, that is the lesion. Go down. Come back, please. Yes, this is the lesion. You know, there is a lipid with calcium. That's why it's so dense. Come in. Since there is lipid, we are not able to see calcium all that well. Come back. Yeah. Come more proximal, please. Yes. Here you can see. Go back into the stent. Into the stent. You can see a 360-degree calcium. So probably the previous stent, whatever was implanted, did not really have normal lumen. So it is significantly undersized due to the calcium which was not treated. Come back. Go distally, under expanded stent. Can you show them? Keep going down. Yeah. Keep going. Yes, yes. Come back, please. Yes. You can see here that the stent is hardly expanded in this region, and there is probably some certain extent of neoatherosclerosis which got calcified. Go down. More distal. Lot of calcium, probably which was not treated initially, has come to haunt him now. Go down. Yes, that's how it looks. So can we hear to your comments on this?
The lesion is seen very clearly. Do you think there is a strut fracture or something which led to that? I don't know. It looks like there is discontinuity, but it's difficult to tell now maybe.
Yes. I mean, at certain regions, you can't even see the stent struts. Probably
Yes.
there is significant calcium even inside of it.
Yeah, maybe. I think you show us what you have done for RCA, then go to live now for the...
Honestly, we wanted to do the RCA, I mean, the left main bifurcation, so we just thought
No
leave
problem.
the RCA where it is. We haven't done anything to that beyond OCT.
Okay, no problem.
See, actually, Girish, the lumen area inside the stent looks to be adequate, somewhere 4, 3.5. The area which you showed,
Yes.
that's saying that it was under expansion, there itself it was 3.5.
True.
But only the proximal edge of the stent there, the lumen is 1.8 or 1.9 here.
Sure.
And probably I think you should concentrate more on the proximal stent edge. And probably, if you're planning for a long stent, then it's okay. Then more concentrate on the proximal part of the stent there.
What do you think, Dr. Selva? Should we just treat the proximal part of the stent and not go into the stent with an IVL, or should we treat the RCA stent with an IVL also? Can I have one more wire?
See, you did a OCT after pre-dilating the proximal part of the stent, isn't it?
With just 2 millimeter balloon.
Balloon,
just
yeah,
take
pre-dilated.
OCT.
Okay, okay. In spite of that pre-dilatation, that looks critical in the proximal part of the stent.
True.
But the middle of the stent, I'm not very sure. But
Should we
probably,
be touching it?
Yeah, because the image is also not so clear. But if you feel it is definitely underexpanded, you don't mind putting a longer stent, then I think you can treat the entire stent. But again, we are not sure at the area of underexpansion. Behind the stent, there is a lot of calcium.
True.
And the role of IVL in the calcium behind the stent is really doubtful. I
Off-label
doubt whether you will get that expansion.
Off-label indication it is. Anyway, I think you go ahead with, do you want to treat this later, but you can go ahead and show the left main what you're planning now. Go ahead.
Correct. You know, can you just show what we had done for the OCT? Now wire the, okay, can you show the LED OCT? We'll show you the OCT of the LED now, next. You can see here, the distal LED is again very, very calcified lesion. Go there. You can look at the area is about 2.9 or so. Keep coming back in. Proximal, please. Come fast. Very calcified. Yeah. Yeah. Slow down. Yeah. You can, as you come in towards the proximal LED, the area really becomes smaller and smaller. Come back, please. Proximal. Yes. This is, the ostial LED. Come back in. Lot of, protruding calcium there. between 9 and 12. Come back into the left main slowly, gradually. Yeah, that is the confluence of circumflex and LAD. Come back. Yeah, this is the distal left main. Keep coming back. The area is less than 4.5 with protruding nodules. At some areas, it's even 4.2 millimeters squared. We are coming towards the ostium. Again, densely calcified. At some, it becomes 4.3 as well. Now go to the proximal LAD. Keep going, yeah, keep going down. Keep going down, keep going down, keep going, yes. Look at this, 2.8, 2.7 millimeters squared. That is the LAD 2.5. This is what we see. Your comments. Circ?
Yes, Girish, it's a left main disease. Area is for 4.5 or 4.4 in the left main with the calcific nodule that you said. And here in the proximal LAD area is 4, and probably the one area it is around 2.8, significantly calcified lesion. And I think probably this is, a patient has come with an unstable angina or a chest pain. I think you should treat it. And if you have any doubt, you can do a physiology also there to make out whether it is physiologically significant down the LAD over the left main. But although imaging clearly shows that this requires treatment, the left main is less than 4.5, which is an indication for angioplasty or bypass surgery in the left main. So when we saw the angiogram, even circumflex seemed to have a very significant proximal disease.
Very true.
Have you done a OCT from the circumflex?
You know, we are in the process. Can you go forward, show the angiograms of the circumflex? Give me that pilot 200 if you have it there. This is the Kipling. There's quite a bit of challenge because it's acute, almost like, you know, 180-degree turn. You need to go in and come out. It is always going to circ. And next, we passed the wire and we wanted to do rota onto that.
Correct. Yeah.
Look at that. The wire is gone, microcatheter. How much ever I drill, the microcatheter would not go down. And we tried to change that into a, you know, different, means I wanted to take a balloon, now we have that 0.6 millimeter balloons for CTO, but unfortunately the microcatheter damaged the wire because that was a Fielder XT what I had taken, and the whole wire has come back. So I'm trying to recross into that segment of Selva.
Okay, Girish, that looks to be a very critical calcium there angiographically, and that too in the circumflex. That is why you are having difficulty in crossing that. So if you are having difficulty, then what you can do is you keep the microcatheter, take it to the point until maximum it goes. From there, why don't you change it to rota wire?
Absolutely. I mean,
keep the microcatheter there and change it to rota wire.
Absolutely. That is the plan. Or should I once try with a balloon 0.6 millimeter if it crosses because of its flexibility? That would allow certainly my microcatheter. Otherwise, you know, I'll have to try with rota wire directly. Come here, hold this.
Microcatheter not going, balloon going is little challenging, I think, but you can try. Think just for the information for all the viewers, that stuck thing which was there in Dr. Kirti's case in from Mumbai, the difficult angulated lesion where they tried to continuously rotablate got stuck. But later on, I tried to pull it with a guideliner inside, still didn't come. But he passed another wire side by and opened up into the branches. And that's how the stuck burr was removed, and later it was stented. The distal to the burr, there was a small perf, which was again closed with a wire. And finally, L6 was opened into OM, and patient is doing well. This is for information. We left in between during lunch break. I wanted to mention to you all, and I told Kirti and Anil that we'll communicate this to all of you.
Thank you. Now, the question is, should we take a 0.6 millimeter burr, continue with the microcatheter, or directly steel wire for rota?
Yeah, but I think if the microcatheter is not, that's a new microcatheter, isn't it?
Absolutely.
Okay, then if new microcatheter is not going, and
Yeah.
I doubt whether your balloon will go there, and even if the balloon goes, if you dilate there, the amount of expansion, I'm doubtful. But anyway, you can try. And after your balloon, if the microcatheter goes, easy. But otherwise, I think you can easily take a rota wire there and just go in.
Track balloon. Okay, I'll follow your suggestion. Can I try the rota wire directly, please?
Girish, you tell us when do you want us to go to other center and come back, but the
I
system
think
is,
it's,
we
yeah,
generally,
it's good time. It's good time. You go and come back. Give me about 10 minutes. I will call you back in when I'm ready with the rota wire.
How
test.
was your guide support, Girish? You
This
want to
is
you want to take some guide extension catheter and then try with that? It might go.
Absolutely.
It can go.
Very true. I mean, 1.25 will go into a 7, guide liner. I will try that.
okay, thank you, Girish. As per your advice, we'll go there for 10 minutes and come back to you. Is that okay?
Yeah.
Okay.
See me?
Yeah, we are with you now. We can see you and take us from the place where we have left.
You know, we have not gone too far. We are just there. I tried the rota wire. Rota wire wouldn't go. Okay. It's the only XT which goes. No other wire goes from here down. So I'm just thinking that I will take a guide liner and try a very small balloon and then plan anything further after that.
We are joined with Dr. Ajay Kirtane and Mircelo Farank now. Can you just show one shot of that previous nodular type of calcium with eccentric disease once? Let them have just a brief look about it.
Yeah. Can we go back, please, if you don't mind?
Just 1-2 shots, go back.
Please go back. Wait, don't do anything. Go back, show the diagnostic. Please come back. Yeah. Come back, please. Come back.
Yeah, I think here they can see it.
Yes, here.
That's a lesion.
That's the lesion, very eccentric, and whole of that is calcium nodule.
Yeah. Which microcatheter do you have?
This is Corsair.
Corsair. Sometimes, and sometimes a fine cross may work. It just has a different sort of transition. The problem is you have to get it to hug that inner curve. The other thing is if you've already swapped the wire out, the XT doesn't give as much support. So, potentially, just swapping for, like a Gladius or a Pilot or something like that, if only the hydrophilics cross. But I think I would try that and then also manipulate the guide up and down to see if you can approach it with a different angle, maybe even deep breath to see if you can sort of sneak it there. But this is a challenging case for sure. And then if that doesn't work, then we talked earlier today about, things like laser or otherwise.
True.
Even a few days back, I had a really similar case, and I tried different wires, I think 5 or 6 different wires, including finally Gladius, probably from Asahi, and it was not working. Finally, I could cross such very similar lesion like this with Sion Suo. It's really, you make shape, you have to make shape, and Suo found the way, and then I could finally manage this case.
Here he crossed with the wire, sir. That was
orbital
not a problem. Wire went in easily.
Yeah.
Only problem is later nothing is going. Only a fielder FC is crossing.
And the anchoring, it looks like an anchoring as well. That's a reasonable try.
Okay.
And you're spinning, right? But don't spin too much because the tip will get caught.
Absolutely. Maybe 5-7 rotations. If I don't get through, I'll come back and again try a rota wire. Go 6-8 here on the LED. 8-10. Come, hold this. Okay, I'm going to spin this. Push the wire in. Don't think.
Yeah.
Be careful. What sometimes is also working just to take care of it, and sometimes it's really
I
low
would try the fine cross. It may be
Okay.
too big, but see.
Okay, I would try
And
caravel.
Caravel too. No, I mean,
Sure, we shall
it's-
give a
it's
try.
same-
Can you give me a micro? Change this. Let me just grab this.
You
Did you
go
tr-
with the guide extension, no? Go with the GuideZilla
Yeah.
or extension plus. Over that, you take that.
What you could do is also to take 5 French guideliner, then to put into the Sur costume. But it's very important to have protection wire in LED, which you already have done. This will
Right.
be also option.
Okay, give me a guideliner. 6, or you would like us to have 6 may help us with a 1.25 bar. Do you think we should use it?
possibly. What size guide do you have? 7?
7. 7.
Yeah, do you have 5 French guideliner?
5.5 we have.
Yeah, 5.5 is fine.
5.5.
Yeah.
Yeah. Give me that.
Do you have a trap liner or no? Because the only thing is that with the mic you're going to have to use a microcatheter. And he tried 1.0 balloon or 1.25 balloon.
Not yet. That would be my next try. To use a
If there is no option to cross with smallest balloon, with the smallest microcatheter, then the only option will be try to go with rotawire direct. If those,
And that didn't work. Yeah.
this probably doesn't work. Maybe Viper wire for orbital could work. And then next option will be to use laser.
Yeah.
Okay. I think that would be the plan. Now let me try this micro, I will try a small balloon inside this guideliner. Give me, please. What happened? Take out that LED wire.
Now, is the guide liner, it's excluded the other wire?
Yes, it's excluded the other wire.
And just be careful at that distal left main.
Exactly.
Just take the microcatheter ahead first.
Okay.
Yeah, don't push it there.
1.1 point. We have 0.75 into 8 balloon. Can you just show there? A CTO balloon.
Yeah, you can try now.
Yeah.
Maybe you're lucky. Yeah.
Yeah. Show the camera.
This could make procedure.
Is it a
bit
Nick
easier.
Nano or what balloon is it?
Yes. This is called Alveo HP, balloon dilatation catheter, CrossMed.
The same thing and a more stiffer wire would have helped. This Fielder XT is good to cross, but support is very poor.
Yeah,
Just,
that's
backs
correct.
out.
That's really the problem. Yeah. But,
I mean, the fact that the body of the wire gets through, because remember the tip is tapered, but the rest of it is a little bigger. So I suspect that with a Gladius or a Pilot, it should be able to cross.
this is one option. Other option will be also to try one additional CTO wire, like Gaia will be option, or Miracle.
Yeah.
Mm-hmm. Okay.
Nothing.
But don't lose wire in LED, because in case of troubles in left main, this will be life-saving.
True. I don't think
That's
the
not going to
wire
go.
That's
That's
not
not going to
wire
go.
is not going to support us on this.
So if you try many times and it doesn't work, the only option will be either you try with smallest balloon to make predilatation as distal as possible, or you let microcatheter as distal as possible and then try to
Or the wire
cross
balloon.
with rotawire.
Yes, I tried that. Rotor wire is not taking. Only hydrophilic wires are able to take that bend and go in the true lumen. Otherwise, I'll have to go through a false
Right.
and then re-enter. But then rotor would be a challenge, isn't it?
Yeah, I mean, which actually might be the solution, but I still would try with a hydrophilic, more supportive wire.
I tried even Pilot 200. I could cross, but the same balloon is not going on Pilot 200. So
Maybe you try again with a Gaia wire. This could
Gaia.
work. Do you have Gaia?
yes, Gaia.
Yeah, try.
You have both. No. Can you give me a?
Will
Or should
laser
I
help
try-
here? Will laser help to
Yeah,
just
I mean, I
create the
think
root?
this is the case for laser,
Laser.
for
What about wire
sure.
balloon?
Definitely no contrast because it's at an angle, so you have to be careful
1
with
mm.
it.
Extension is there. Okay?
Or and did he try to rupture the balloon or no? Not yet.
Till next we have a talk on this wire crossed balloon uncrossable lesion. I think Girish, if you want to work in peace, we have crossed the time. Then we'll have some lectures and come back to you whenever you want to see the result.
That's fine.
Okay, we want you to be comfortable and do what is best, and we'll come back to you. Don't worry.
Thank you. Go ahead with your lectures.